Hello, everybody. My name is Simon Ruth, and I'm the CEO of Thorne Harbour Health. I'd like to start today by acknowledging that it's Reconciliation Week, and I'd like to acknowledge the traditional owners of the various lands on which we are meeting. I'm coming to you from the beautiful and wet lands of the Wurundjeri people of the Kulin Nations, and I'd like to pay my respects to elders past and present and acknowledge any First Nations people with us today. Welcome to the launch of this report titled The Cost of Adverse Mental Health Outcomes in the LGBTIQ+ Victorian Adult Population. Following the Mental Health Royal Commission, Deloitte approached Thorne Harbour Health wanting to explore what is happening for LGBTIQ+ Victorians, and we embarked on this journey together, producing a report that we believe is the first of its kind worldwide. This could only happen in Victoria due to the great work of the Victorian Agency for Health Information at the Victorian Department of Health and the Australian Research Centre in Sex, Health and Society at La Trobe. And the report is certainly only possible through the support we have received from Deloitte Australia and Deloitte's LGBTIQ+ and Ally Network Stand Out. We thank you, Deloitte, and we thank you, Stand Out, particularly Bonnie Rowe and the team who worked on it. Today, you'll be hearing a presentation of the findings from my colleagues at Deloitte, followed by a panel discussion facilitated by Professor Adam Bourne. Due to the size of the audience, we're operating in webinar mode, but please feel free to use the chat and the Q&A functions, and they are being watched. So without any further ado, please allow me to introduce you to Luke Condon, Engagement Partner, and Jennifer Gong, Health Economist, both in the Health Economics and Social Policy Group at Deloitte Australia. Over to you, Luke.
Thanks for that, Simon. Thanks for that introduction. And yeah, we've also really enjoyed working with you on this project. It's been our privilege to do so. So my job today is to start the presentation regarding the findings and outcomes of this report that we've undertaken, as Simon was speaking of. Jen, if it's okay, I might just ask you to bring up the slides. Thanks for that. And I'd just like to echo Simon's comments there regarding the support that we've received from Thorne Harbour Health and everybody else who's been involved, and also from within Deloitte, from Stand Out and the Deloitte Foundation and others. So thank you everyone for their support in assisting us to prepare this report. If we just go forward, thanks Jen. I also just wanted to echo Simon's comments there in acknowledging that we are meeting on Aboriginal lands, and pay my respect to elders past, present and emerging also. So just by way of introduction, I'll cover the overview part of this presentation, and then my colleague Jen Gong will talk in more detail about the analysis and findings, and there'll then be time for a panel discussion, including any questions that you might pose during the session. So please, we encourage you to do so. And this report is also going to be made live on the Thorne Harbour Health website during this webinar. So while what we're presenting is a summary presentation, you can obviously delve into the full details of the report at your own leisure. So I've just put on the screen there kind of the formal purpose and objective of this project. But as Simon alluded to, we last year, or it might have been the year before last actually, had some discussions and done some webinars with Mental Health Victoria, and they had raised with us some of the distinct mental health risk factors experienced by the LGBTIQ+ community. And so we approached Thorne Harbour Health about potentially doing a study such as this. To our knowledge, not only was it an area that needed further analysis, but we weren't aware that something like this had previously been done. And so we've estimated in this project the economic cost of adverse mental health outcomes. So that includes anxiety, depression, suicide, suicide attempt, and suicide bereavement in LGBTIQ+ adults in Victoria in 2019. I'll go into more detail about the different types of costs that we've looked at, but suffice to say it includes financial, economic, and intangible well-being related costs. And we look at that from an individual, chosen family and friend, government, employers, and society perspective. And it's hoped that this study will provide important evidence to inform decision-making regarding the continued investment in mental health in Victoria, specifically tailored to the needs of the LGBTIQ+ community and communities. So Jen, we might just move forward if that's okay. So the method or approach that we've used in this study enables the measurement of the economic burden of a condition or risk factor. And these types of studies are often done in health economics, and they are instrumental in public health policy debates because they translate whatever the adverse health condition is, so in this case, mental illness or different types of mental illness, into dollar terms, which provides evidence to inform new programs or investment decisions. So in this particular instance, it's estimating the economic, financial and intangible or wellbeing costs of mental illness in the LGBTIQ plus Victorian adult population in 2019. We have, as I mentioned, undertaken similar studies previously. We've provided some examples there. Each one of them tends to be different and throws up a different set of considerations and complexities, but it is something that we're accustomed to navigating. This is kind of the framework, if you like, that has been used to guide this project. So I might just talk you through this. So when we do this type of work, it's first of all important to understand the prevalence of whatever it is that we're looking at. So in this case, anxiety, depression, suicide attempt and bereavement across the community that we've referred to, and that includes mortality as well. For that first group there called quality of life or loss of well-being, which is referred to in the report as the intangible cost, that looks at years of healthy life lost due to morbidity and also years of life lost due to premature death. And it's then possible to estimate that in cost or economic terms using the value of a statistical life year. Then when it comes to that next group under the heading of economic burden, and as I mentioned, we look at this based on each of those different levels, individual, families and carers, government and society. We can look at that in terms of the cost to the health system of higher levels of mental ill health amongst this particular group. So for example, the increased cost of hospitalisation, mental health services, medication and other out of hospital costs. And we also look at it in terms of productivity costs. So these are some of the economic costs like absenteeism, reduced workforce participation and presenteeism, as well as those other categories there. There's then other costs that we look at, as mentioned, the cost of government programs or police or coronial costs. Those costs are important because it demonstrates the very broad and holistic approach that we've undertaken, but they're relatively small in the grand scheme of things. But nonetheless, we do try to capture them as best as we can in the report to give as full a picture as possible. Although invariably when you do projects like this or analyses like this, there are limitations on what you can and can't quantify and measure. And there's also some data limitations or issues that you need to work through, but we are very careful to call those out and explain those in the report. Jen, we might just move forward, thanks. So probably the main thing I think that will be of interest to everybody here to call out is the Thorne Harbour Health leadership team has been closely involved in providing oversight and guidance throughout this entire project. There's also been informed stakeholder engagement, including from the LGBTIQ plus community or communities, and they've provided further guidance and expertise at key points as required. Some of the stakeholders we engaged with included the Productivity Commission in the context of the mental health inquiry they did a couple of years ago, both the Department of Health and DFFH in Victoria, the Northwestern PHN, the Australian Research Centre in Sex, Health and Society, Mind Australia, University of Melbourne, and also the Victorian LGBTIQ plus task force, the new commissioner, Switchboard, Telethon Kids Institute, Transgender Victoria, and there were probably others. So it was a consultative process, and that was also reflected in the governance model as well. Jen, we might just move forward. I also just wanted to call out that in speaking with stakeholders and LGBTIQ plus communities throughout the project, there was very strong feedback and this is consistent with our approach, that while it's really important to try and quantify or monetize these costs or impacts where we can, that can't really tell the whole story. So there are some aspects of complexities or contextual factors surrounding mental health in LGBTIQ+ communities that are not necessarily able to be captured through economic modelling. So they're described qualitatively in call-out boxes throughout the report. And some of these go into quite some detail, like about a page each in the report. So just to call out the things that are covered in that way, the particular impact of alcohol or other drug use, the impact of sexual concealment on the health and well-being of LGBTIQ+ people, Aboriginal and Torres Strait Islander people's LGBTIQ+ mental health risk, suicide risk relating to conversion practices, understanding the unique and widespread impact of suicide in the LGBTIQ+ community, health system experience of the LGBTIQ+ community, including some of the barriers or prejudice that are still faced, and also the impact of informal care on the health and well-being of carers. So they're all covered in the report, even though they're not explicitly part of the economic modelling. So from the perspective of myself, who was responsible for the project as a whole, as the engagement partner, that's all that I really wanted to say. And now I would like to pass over to Jen, who'll go into a little bit more detail about the actual analysis and results. Thanks, Jen.
Thanks very much, Luke. Hi, everyone. I'm going to walk us through the key findings from this study. Before I begin, I just want to emphasize again the scope of this piece of work. So we looked at 5 conditions that represent those for which there is robust data and literature available. They also represent conditions which have a significant impact on the quality of life of a large number of LGBTIQ+ individuals. And so we considered them as high prevalence conditions. So what that means is that in the report and in the findings that I'm about to show you, they don't cost or comment on other conditions such as psychosis or substance use disorder. And so when we talk about the adverse mental health outcomes, the economic cost, we're talking about anxiety, depression, suicide, suicide attempt, and suicide bereavement. So I am now going to show you the cost summary page, and I'll walk us through these. So the total cost attributed to the 5 outcomes, so the anxiety, depression, suicide, suicide attempt, and suicide bereavement in the LGBTIQ+ Victorian adult population in 2019 were estimated to range between $19 to $25.4 billion. And as you can see on this slide, we've broken those costs down by economic and financial costs. So that's the $2.2 to $3 billion, and the intangible costs, the $16.8 to $23.4 billion. For those who don't have an economics background, I'm going to explain to you what those definitions actually mean. I like to think about economic costs as costs in which there's a person who interacts with a service. So, for example, a person who goes and uses a health service, for example. So they're our financial costs. Financial costs. So economic costs, these don't include a direct financial exchange between members of society, but they're actually real costs to the economy. So these are costs such as productivity losses. Luke mentioned intangible costs, and these are non-financial costs, but these are costs that we think about as loss of well-being or burden of disease due to the loss of well-being through reduced quality of life, associated injuries, or premature death. So you can also see in this diagram here is that we have the cost that is disaggregated by conditions. And what we've done also is try to highlight how much of those costs under each condition are economic and financial costs, and how many of those are intangible costs with the baby blue and the light aqua color, I guess. What I want to point out is that the costs that are really driving the total economic, financial, and intangible costs are those associated with anxiety and depression. And when we look at what's really driving that, and I'll explain that in further detail in my next few slides, is that that's really driven by the high prevalence of anxiety and depression in the population. That's not to say that the costs for suicide, attempted suicide, and suicide bereavement are small. They are also quite substantial. But when we think about what's really driving those, the high costs, they're really from the diagnosed anxiety and depression in the LGBTIQ plus Victorian adult population. I'm going to move on to the next few slides, which talk about our findings, but also how we think about economic burden studies. The next slide I'm going to show you is how we estimated the size of the LGBTIQ plus adults at a Victorian adult population. And so in the absence of an alternative data source that more readily captures gender identity, sexual orientation, or intersex variation, prevalence of the LGBTIQ plus adult population was calculated using two approaches. So what I have here on the screen is the two approaches. We have an upper bound estimate and a lower bound estimate, and I'll explain a little bit in detail about what that means. So Simon mentioned a study, which is he mentioned the Victorian Agency for the Health Information, so VAHI Victorian Health Survey. And we use that survey in the lower bound estimate to determine the prevalence of LGBTIQ plus Victorian adults in the population. That survey estimates that 5.5% of the Victorian adults identified themselves as LGBTQ plus in 2017. Through this project and with discussion with Thorne Harbour Health and with various stakeholders, we landed on the approach that it was important to include intersex in the population. And so we had a look at the existing data to see what we could use to inform our prevalence estimate. And so the source by Blacklist indicates that 1.7% of the population is considered to be or broadly accepted as the most accepted source to estimate the intersex population. And so using that 5.5% from VAHI and the 1.7% from to estimate the intersex population, we land at the lower bound estimate of 7.2% of the Victorian adult population, identifying the LGBTIQ plus population. And so that's going to be, and in our estimate, that we estimate that to be about 372,000 people. The second approach that we took was through discussions with stakeholders, where the 5.5% that was mentioned in the VAHI or estimated in the VAHI study, it was considered an underestimate. And so we wanted to propose another estimate in which we had an upper bound prevalence. And so we went back into the literature to have a look at, what was existing out there to be able to allow us to have the best available conservative upper bound estimate. And so there is a report that's published by the OECD, which summarizes the prevalence of LGBTI in OECD countries. And so looking at the prevalence values that were reported there, we, in agreement with Thorne Harbour Health, decided that the upper bound estimate would be 10% of the Victorian adult population. And so in number of people, that's about 517 to 18,000 individuals. The next part of this analysis was understanding what the prevalence of adverse mental health outcome looked like in the LGBTIQ plus adult population. And so what I have here on the screen is the prevalence rate, but also the lower bound and the upper bound cases, or the number of individuals impacted. So in short, for anxiety, depression, and suicide attempts, the source that is primarily driving those prevalence is from the Private Lives 3 survey. So I'm sure many people on this call are familiar with that source, but we've also looked at other sources to try to also include the prevalence for the intersex population. So for anxiety, the prevalence rate in the LGBTIQ plus adult population is 28.5%. We estimate that the prevalence of depression is 32%, and suicide attempt is 4.3% of the LGBTIQ plus Victorian adult population. And we've got the lower bound and upper bound figures reported there. I want to spend some time talking about suicide and suicide bereavement and the methodology. And what I touch on in today's presentation is only a brief overview of the methodology, and the report goes into much more detail of how we land these numbers and the sources that we use. As many people who work in this area know, that the Coroner's Court of Victoria and the ABS, or the ABS Causes of Death publication, doesn't actively report or publicly release LGBTIQ plus specific death data. And so what we had to do is go back into the literature to look at what methodology could be used to inform our analysis. There is some literature that suggests that as many as 20 people may attempt to end their lives for each suicide death. And so we used a conservative ratio of 20 suicide attempts for every one suicide was used to estimate the number of suicide deaths in the LGBTIQ plus adult Victorian population. And again, the lower bound and the upper bound estimates are shown on the screen. We also wanted to include in this scope of work suicide bereavement. When we look into the literature, there is literature that indicates that typically 7 people are directly impacted by a suicide, and that's considered in the literature as the inner circle. There's also literature that looks at the more wider impact. So for example, if you look at the outer inner circle, there's a further 13 individuals that are impacted from a suicide. And then when you look at the outer circle, up to 135 individuals are impacted by a suicide. But for our costing methodology, we've only considered the cost pertaining to the inner circle of 7 people, just because it is a conservative approach. I do want to be mindful and note that a death by suicide of an LGBTIQ plus person has significantly broader and widespread impacts across the rest of the LGBTIQ plus population. And that's due to the dynamics and relationships within the community. For our analysis, we've only included that the 7 individuals impacted by that suicide, and the report describes and talks in qualitative terms the other impacts that I just mentioned. So I'm going to move on to the slides which give you a better breakdown of the costs, and particularly which services or which cost components are being captured for each of the 3 larger cost components. So I'll start off with financial costs. Again, financial costs are those costs in which there's an individual that interacts with a system or a service. So for example, someone who goes to the hospital, for example. So we estimated that the total economic costs attributable to adverse mental health outcomes in the LGBTIQ plus Victorian adult population in 2019 was estimated to range between $413 and $508.8 million. And so if you have a look at the table on the right here, we've got that breakdown of financial costs. So for our analysis, we included health system, funeral, formal care, coroner inquiry, police, and pre and post pension funding costs under financial costs. As you can see, that the cost that is really driving the figures are the health system costs, followed by the informal care costs. So if you have a look at this table here on the right, the dots really indicate which costs were being captured for each condition. So for example, when we look at the health system cost component, we costed that for anxiety, depression, suicide attempt, and suicide bereavement. When we look at funeral costs, that's only captured for the number of suicides in that population. I also want to note in the top, the report goes into much more detail that when we think about these costs, we describe in more detail in the report what are the actual services being used. So for example, in health system costs, you'll see in the report for suicide attempt, we have estimated the immediate health system costs following a suicide attempt, but also importantly, we have estimated the long-term health system cost from a suicide attempt. And so I just want to be mindful that we sort of have described that in much more detail in the methodology in the report. So I might sort of just finally touch on formal care costs and how we landed those. So formal care costs are those where those that are permanently incapacitated following a suicide attempt, they've been assumed to have ongoing formal care costs. So I'll move on to economic costs. So economic costs, again, as I sort of mentioned previously, these don't result in a direct financial exchange between members of society, but they are real costs to the economy. And as you can see, that the total economic costs attributable to adverse mental health outcomes in the LGBTIQ plus Victorian adult population in 2019 was estimated to range between $1.8 to $2.5 billion. Again, if you have a look at the table on the right, the two key components are productivity losses and, well, dead weight losses. So, for example, if you think about productivity losses, if a worker's productivity is lower due to injury caused by suicide attempt or because they live with anxiety, depression, the firm's output may be reduced. Therefore, that incurs a cost to the firm and to the government, for example, through reduced taxes. And so that's what we mean by financial costs. As you can see, we've disaggregated financial costs by different components. So we've got premature mortality, permanent incapacitation, that's associated with suicide attempt, reduced employment, absenteeism. So someone who, because of their mental illness, they're taking additional day off from work. Presenteeism, this is when an individual turns up to work, but they're not working at 100% of their productive level. There's search, hiring and training costs and informal care costs. As you can see, for economic costs, the costs that are really driving that are the presenteeism costs, followed by the absenteeism costs. And again, the table on the left is just indicating and showing everyone in the room what components were being costed across the 5 outcomes. I might just mention again, so what dead weight losses mean. An example of dead weight loss is, for example, lost taxation revenue or additional expenditure to fund the provision of government's programs. Finally, this is the last slide, which are those intangible costs. So the total intangible costs attributed to adverse mental health outcomes in the LGBTIQ plus Victorian adult population in 2019 was estimated to range between $16.8 to $23.4 billion. So intangible costs in this study are the loss of well-being costs due to adverse mental health outcomes in the population. And this is in the form of reduced quality of life, associated injuries and premature death. I'm going to spend a little bit of time just talking through the methodology of intangible costs because they're very large, but I also want to give you a sense of how we landed these values. So intangible costs are measured through something known as the burden of disease methodology. And in essence, it's measuring the disability adjusted life years. Basically, it is trying to total the number of years lived in imperfect health across the population. And you can actually convert disability adjusted life years or DALYs into a dollar figure using an estimated value of statistical life year. So that's basically what is the value that society places on 1 year or someone's life for 1 year. And in Australia, in 2019 dollars, that's $213,000. And so in essence, this methodology is adding all of the years lived in imperfect health by what society values that person's life. And so that's how we land on that $16.8 to $23.4 billion. Again, this is nothing new, but this is my final slide. I want to end with this slide just so that hopefully through the presentation between Luke and I, it gives you a sense of that stepped approach to how we landed these costs. And again, the report goes into much more detail, particularly the technical appendix, which speaks to the methodology and all the sources used. Thanks very much for having me. I'm going to pass over to Professor Bourne, who will moderate the panel discussion.
Thank you very much, Jennifer and Luke, for not just a really valuable and informative presentation, but also the tremendous amount of work that I know you and the rest of the team of Deloitte have put into this over the last, well, it feels like 12 months or so. I know there's an awful lot that happens in the background in calculating those figures. I'm also conscious in hearing all of that we've been discussing subject matter in a very technical way, given the nature of health economics. It's a language that can feel a little unfamiliar sometimes, and can sometimes feel a little blunt as well in the terminology that's used. But behind every one of those statistics, behind every one of those numbers is a real person, and a real person who's affected by mental health or by suicide. And so I do just want to encourage everyone who might feel affected or impacted by the nature of the discussion, just to think about the mechanisms of self-care that you might have available to you, reaching out to any friends or family who might be able to support you. And if you need to, of course, making use of some of the professional services available as well, such as the Rainbow Door operated through Switchboard. And we can pop the details for those in the chat function as well, if that's useful. As Jennifer said, I'm Adam Bourne. I'm Associate Professor of Public Health, and I'm Deputy Director at the Australian Research Centre in Sex, Health and Society at the Trobe. So a lot of my work sits in the realm of LGBTIQ health and wellbeing, particularly, in fact, in mental health. We've always known and we've lived the emotional cost and psychological cost for LGBTIQ communities of mental health. That's what we hold in mind every day, and I think this report helps us understand how it translates to an economic cost as well. And the outcomes of that analysis are quite startling. I'm joined today by 3 panelists to explore their perspectives and to think through what we can be doing further in partnership to help address some of those issues. And those panelists are Janet Jukes. Janet is the president of Thorne Harbour Health, current member of the Victorian Government's LGBTIQ Task Force, and co-chair of the LGBTIQ Justice Working Group. Janet also works as CEO of Relationship Matters. Alongside Janet is Joe Ball. Joe is a long-standing LGBTIQA+ activist and is CEO of Switchboard Victoria, a leading community-based organisation that provides peer-driven support services to LGBTIQA+ people, their families and communities. He's also a member of the Victorian LGBTIQ+ Government Task Force. And finally, Bronwyn Lawman. Bronwyn is an experienced mental health leader with over 30 years experience in a variety of healthcare services. And Bronwyn is currently the operations director at Peninsula Health and Mental Health Services. Welcome to you all, lovely to see you all on the screen. I'll start by a pretty broad question to begin with that I'd like each of you to take a moment to respond to. These are really big findings. And what are your initial reflections on this research and on this analysis? And Joe, I might throw to you in the first instance.
Yeah, thanks, Adam. And I think I appreciated what you said about if you like, the brutality of the banality of that it looks like these numbers on a page. And I think that when I see that, yeah, I do absolutely see people, and I see people that I know that have been lost to suicide, and people that I know that live with mental health issues. And, I see them around them, and I see it in our community all the time. And of course, I professionally see it because I work for Switchboard Victoria, and we run 2 7-day-a-week helplines, and we run an older person service, and we see this. So I'm not surprised, and I'm also always moved by the numbers. And I think that we should never, stop paying attention to that, and we should never become complacent with the huge high numbers in our community of suicide and poor mental health. I think that it's really difficult to grapple with some of this data because it is a model that is talking about putting numbers to health. But what we've seen recently is we've seen 2 budgets, both the Victorian budget and the federal budget, where we have seen money distributed, and it's not at the proportion that reflects the mental health crisis, both in our state, Victoria, or nationally within our communities. And so it has put back this pressure for us to actually make these economic arguments. And so I do welcome this report. I don't think it is ever the only way we should talk about our communities at all. I think that we need to talk about these communities and centre the lived experience of people who have survived suicide, who live with suicidal thoughts and live with poor mental health. And yes, we should count, as Jackie Browns is saying in the chat, we should count the positive contributions that people with poor mental health make. Unfortunately, it is very hard to make that argument, and we do need to put numerical numbers on it. And I feel that we've been drawn that way, drawn to those arguments. And I think that they need to be made alongside hearing about the lived experience and talking about the contributions that people make as well. I think we need this report. I don't think it's the only report that, you know, as I said, I think this is clearly an undercount, and we've heard about that from Jennifer. Like, I think that we don't actually have baseline testing in Australia of how large our community is. And they decided, the federal government last census, to again not provide baseline testing, that is what the census provides. It's not a hug of how many, it's not just so we just know how many people we are. The census provides baseline testing. If we had baseline testing, we would have a far greater idea about how big our community is. And I think it's definitely bigger than what is in this report, but we must come back to the evidence base. And that's what this report has done. So we're in a data deficit model. And I think within that, this report has done the best job possible at this time to give a numerical figure, and with all the problems that a numerical figure provides. But it needs to be part of the conversation. And I think the other amazing thing that this report does is talk about the consequences of prevalence within our community. That stands out to me. And I've been a big advocate about this for a long time, is that when we lose one person to suicide in our community, it affects over 100 people or more. And this report makes an evidence base for that. And I think when there is poor mental health and suicide at the high rates in our community, it means that everybody probably who's in this meeting tonight has lost someone to suicide. If you're LGBTIQA+, you have probably lost someone to suicide. That's what the prevalence means. So I'll leave it there. There's lots more for other people to contribute.
Thank you so much, Joe. Those are really, really valuable reflections to kick off the discussion. Bronwyn, I might turn the mic over to you, and the same question, really, your initial reflections on the research and what it's telling us.
This is really important research, and it's really fantastic to see it done. It's the first time I've seen anything like that, and having worked in the sector for a really long time, I know the rates are really high. I've been impacted by people suiciding that I care about from our community, but the rates of anxiety and depression and suicide and the bereavement that goes on within communities is really alarming. And the financial and emotional impacts are just enormous. And, you know, today we sit here talking about this, and it is people behind all of this, and it's kind of distressing content in a way. The impacts on carers are enormous too, and the flow-on effects that anxiety, depression, and suicide has. But the thing that really struck me is yet so little is spent on our community compared to the overall budget. And if you look at the Royal Commission, the amount of money that's being spent on that in mental health care, and that's catching up over the last 20 years of underfunding, it felt like we got virtually nothing for our communities. And we're a significant part of the population at 10%. And I think the other thing that runs through our community is trauma. The trauma of so many years of having to be underfunded, unrecognised, living in the closet, all the different forms of entrenched discrimination that people have encountered, and at times a real lack of awareness by mainstream services. a persistent lack of funding over so many years, it's going to take some time to really right these issues. But it's very traumatic for people, and trauma is what we see in people coming into our emergency departments across the state. People are traumatised. Yeah, that's probably what I'd like to say about it.
Thanks, Bronwyn. That was a really valuable reflection, both on the human dimension of it once again, but also the kind of partnerships that are required to try to address the issue going forwards. Janet, your reflections.
So my initial reflection is, and obviously, you know, I was involved from the beginning in terms of trying to drive this research, and it really, just in answer to Jackie and Mama and others around it putting a number on something that's so negative. You know, I think as Adam talked about, and Joe, we've been kind of put in this position because of the need to draw attention to the impact on LGBTIQ people themselves. If you look at the report in a bit more detail, it's actually about 80% of the cost of inaction to address discrimination and stigma is borne by LGBTIQ people themselves and the service system. So that's where and you know, in many ways we like to talk about, you know, marriage equality and everything's just fine now, and we all know that that's absolutely not the case. So I think the thing that surprised me most though about the report when I first read it is it's a big number, and I wasn't shocked. I expected it to throw a big number, but I didn't expect it to be this big a number. And we're talking about, you know, $500 million in financial costs, the economic cost being, you know, $2.5 billion, the intangible costs being $7 billion to $23 billion. These are huge, huge numbers. And I think it puts a really strong case to support the government's agenda, because this government has been better than any other government in terms of an agenda around preventing discrimination and promoting inclusivity of LGBTIQ people, and we really thank them for that. But it really puts behind that, I hope, really pushes along a momentum to say, you've got to keep investing, and you've got to invest in service responses that are going to really work for our community. So, you know, just acknowledging that this is health economics. It's brutal, and it puts down a number. And in order to come up with that number, you have to talk about the terrible impacts on people. But behind that are the people who are bearing the burden of inaction and lack of investment in our communities, and the lack of infrastructure and support. And so this is hopefully a report that will say to government, if you invest a little bit more, then not only will you reduce human suffering, which is what we want to see, and you'll help us all live our best lives, but also it'll cost less, and the taxpayer will pay a lot less. So that's really what it's about. And I think the other point I wanted to make is the thing that also really shocks me is that the impact of mental health is particularly shocking when we notice that all of this cost on humans, but also cost to society, is preventable, because it's not LGBTIQ plus people who are the cause of mental illness. It's the impact of the system of discrimination and marginalisation, and the individual and collective trauma from us all living our lives in a society that has in the past and continues to discriminate against us. And so that's what wears us down. That's what caused the anxiety, the depression, the suicidality, and the cost of all of that. And it's totally and completely and utterly preventable. And that's what we're really trying to say in this report is, here's the cost. We don't need to have that cost. The individuals don't need to bear that cost. Society doesn't need to bear that cost. And so we hope that this will really support the government, the Equality Unit, our Commissioner, the Mental Health Royal Commission, and others, to say, you know, invest here and you'll get big bang for your buck.
Thank you, Janet. A kind of really nice way of summing up some of the ways in which I think some of these data can be utilised all across our sector of community organisations, mainstream organisations, and indeed within government, having that piece of paper to say, here's why we need to be making this investment in the places that they continue to do so. Bronwyn, I might circle back to you if that's okay, and on that related point, ask kind of what you understand or feel the role of more mainstream mental health services can be in addressing, tackling some of the issues that have been raised thus far in the panel discussion and are so evident in the report. And perhaps if I can just supplement that question by making reference to a question that's come in the chat by asking if you're aware of how the private sector services are engaging with LGBTIQ communities in relation to mental health as well, if you feel able to answer that second part.
Okay, I might start with the mainstream services, which is where I work essentially. I think a number of things can be done locally and at a system level. One of the things that would be really important and probably a quick win to develop would be increased training provided by or delivered by specialised LGBTI community controlled organisations. And that can be rolled out across the state through a body like Safer Care Victoria or the Office of the Chief Psychiatrist. And one of the first focus points for that training, which I think should be across the state, would be the emergency departments. That's where we see people at their most vulnerable after they've had a suicide attempt or they've come in and they're at their wits' end. And the impact of those interactions on people is so important that we get that right. It's really the first point where a lot of people end up. The other thing that I think is really important is the establishment of key partnerships that are actually formalised that allow more seamless referral onto specialist community controlled organisations. And new care pathways are actually developed and established so that it's easy for clients and their families to get the support that they need. But to do that, we need to build more capacity within the community controlled services so that they can take on more clients like Thorne, Harbour and Switchboard. They need to be funded properly so that they can pick up clients quickly and be responsive. The other way that I think we could have an impact across our state is through the new HOPE teams that are being established in all public mental health services. They are there to help people who have attempted suicide or are thinking about suicide. They could develop more specialised service offerings for the LGBTI community, included after hours service provision as well, because a lot of things happen after hours. It's not all Monday to Friday, as we know. The other thing that I think is worth considering is how we can encourage and positively promote accreditation processes like Rainbow Tick, or set up a new set of minimum standards that again should really be rolled out to mental health services through the Chief Psychiatrist or Safer Care Victoria. We've done that on other things like reducing restrictive interventions, and we know that that works. Services need assistance financially too to be able to do those things. It can make a huge difference, and we've recently been through the Rainbow Tick accreditation, and it's actually had a really positive impact in our organisation. The other thing that our mental health staff really need is probably a series of statewide communities of practice for staff wanting to increase their skills in LGBTIQ practice knowledge and dispel some of the myths. There's not a lot of training like that really provided. There's not a lot of support. I'm not aware of any communities of practice actually operating like that. In terms of private mental health, I'm not aware of any specialist sort of private offerings across the sector currently, but others may be aware of those. It's probably a gap in our private system.
Thank you, Bronwyn. I might just slip over to Janet, knowing that in your day job will work within a mental health organisation, well, have done in a variety of roles in the past at least as well, and ask you a similar question around the role of mainstream mental health services.
So I'll probably get myself into trouble because technically I'm the head of an Anglican agency, but I think in addition to all of the points that Bronwyn made around partnering, around training, about accreditation, there's also an important component about this, and that is that many of the organisations that are our largest service organisations are also have their roots from organisations that have caused this harm and continue to cause this harm. And I am, just to be very explicit, to get myself into even more trouble, I am talking about faith-based organisations that, as recently of the marriage equality campaign, and even more recently, we continue to see examples even in newer community faith organisations, Muslim organisations, and so on and so forth. We continue to see discrimination perpetrated against LGBTIQ people. And I think that a very important bit of the mix is for those organisations to recognise that they shouldn't be doing this work, this specific specialist work for LGBTIQ people. I think they can improve their service delivery, but when there's specialist money, then we really need organisations that people can approach that don't bring up their history and the history of the discrimination that they've experienced. So that's probably a little bit controversial, and it's certainly controversial from the seat that I sit in as the head of an Anglican agency. But I think the way that those organisations can contribute is by partnering. So it's really, really important that we, as an organisation, as a community, build a service system to address mental illness and suicide in a safe way for people. And part of that is recognising the terrible history that's been perpetrated against LGBTIQ people and continues to be. So that would be the bit that I would add. I mean, in terms of the private sector, I definitely think that there's quite a bit of linkages that need to be built. And there are a lot of fabulous practitioners, individual practitioners out there doing some really, really important work. A lot of them are members of our community themselves, and they're doing some fantastic work with survivors of discrimination and abuse, conversion practices, and so on and so forth, in repairing some of that trauma. But providing better linkages so that so members of our community, when they do access either mainstream service dispersal organisations, or can actually find their way into those fantastic private practitioners is really important. There's also a lot of really terrible work out there because it's quite hard to tell exactly what's going on. But I just want to put a bit of a call out in response to Wendy's comment that in my sense there's definitely some fabulous private practitioners out there. It's just hard to find them.
Thanks, Janet. And I just wanted to add, I guess, my own reflection on the back of yours and Bronwyn's comments. I think certainly Bronwyn mentioned a couple of times the Rainbow Tick accreditation program that mainstream organisations are able to go through. I also just wanted to highlight a more recent publication or suite of publications from the state government, the Rainbow Ready Roadmap, which was launched on Ida Hobbit, and I'd encourage you to have a look at that. It's a resource that I think helps organisations on a road towards ensuring more inclusive practice, some of which might continue forward to achieve the Rainbow Tick accreditation as well. But it's a really great suite of resources that helps organizations think through how they might go, how they can think through their inclusive practices for LGBTIQ communities. So just wanted to put that on people's radar as well if you haven't already seen it. Joe, I'll circle back to you. And we talked a bit about mainstream services and the role that they can be playing in response to mental health. An obvious question, given the role that you occupy, what is the role of community organizations and how can they be a partner in the work that needs to happen going forward?
Yeah, I mean, I think it's really important to remember when we think about our community organizations like Switchboard Victoria and Thorne Harbour Health is that we're organisations made for and by our community, and largely they began in the AIDS epidemic because of the sort of, you know, the rights movement and when it began and when the organisations were formed. And we need to think about how much they were fought for. And I think that's like, there's a history piece that's really important, in that they actually hold the lived experience stories of our community. And that, you know, there's this movement going on, which I'm so behind, of like hearing the lived experiences of people with a mental health issue, and hearing the lived experiences of people who have survived suicide and people who have bereaved suicide. And I think community organisations play this really important role, like Switchboard, where they have heard those stories en masse through our helplines. And we actually play a really important role of advocating and amplifying and supporting the lived experience stories. And I think that, you know, it's about that ideology that came from the disability rights movement, which is that nothing about us without us. And that actually it's very important, if we're going to make changes in the mental health system, that we're going to talk about how money should be spent, that we actually have this voice that is for and by the community, and that these organisations that are community-led have this conversation. Like, everybody who works at Switchboard identifies as part of the community. Our whole board has to be made up of someone who's LGBTIQA+. I invite everyone who identifies as part of the community to join a community-led organisation. Like, these organisations belong to you, and I encourage you to become members of them and have a say in how they are run. So that's a shout out. And I think that they play this very important part in the system. And that's not to deny that there is other organisations that are doing their best to support our community and have long-term standing projects that support our community. But at the end of the day, we have to go back to the idea of nothing about us without us, and that our organisations are established for and by our community. We don't always get everything right. We're all always on a journey around intersectionality and reflecting on that. And reflecting on how we can do things better. But I think our community controlled organisations are the heartbeat and are ultimately have to be at the centre of the response to improving the mental health of our community. And just to finish on the comment about money, I mean, I hate putting money on, I don't like this kind of framing that we have to do, but I think we have to talk about also, if we were not driving down the poor mental health outcomes in our community, if we weren't driving through stigma and discrimination people to suicide, I would love to see that reinvestment. I'd love to see that money saved and go back into our community to make us stronger. An example of that is we spent $122 million on the postal survey. Imagine that reinvestment back into our community. Like, also the way you can look at this is, if we were not, the cost of our poor mental health could be actually what we spend on our, spend on our community as well. Like, there's a way to look at it. There's many ways to look at it. And I think, yeah, I'll just leave it there. We've sort of run out of time today. Yeah.
That was great. Thank you, Joe. A very passionate reminder of the myriad and many ways in which community holds expertise. And I like that framing around we are the heartbeat, and, you know, community organizations, the heartbeat of community, and the expertise that they can contribute is significant. So thank you for that. There has been a question asked by Yar around the extent to which the report estimated the cost impacts of mental health on members of the LGBTIQ community living at the intersections. Jennifer, we've got 2 minutes left, and I need to give 1 minute of that to Janet to wrap things up for us. But I wondered if you could just jump on very quickly, and in about 30 seconds, as quickly as you're able to respond to, as quick as you can, that question, that would be great.
Thanks very much, Adam. I'll do it in 20 seconds. We note in the report the importance of intersectionality, and so we weren't able to cost that quantitatively in the report due to limitation of data. And so what we've done in the report is describe that in a call out box qualitatively, that impact to mental health. And so, yeah, we want to be as robust as possible in the methodology, and with the limitation of the data and the methodology, we weren't able to quantify that.
Thank you, Jennifer. I mean, and having been part of some of those conversations earlier on, it seemed often that there was a great deal of intention and desire to do those kinds of breakdowns and think at the intersections. It was absolutely not a lack of interest or commitment. It's simply about what data is available to inform these kinds of economic models. And we try to be very, you try to be very conservative and very robust in that. And sometimes the data just isn't there to enable that yet, but hopefully that's something that we can be addressing in the future. Thank you very much to all of the panelists. That was a really, really valuable discussion and a nice way to kind of reflect upon the really valuable findings that Deloitte have presented us with. Janet, I'll hand it over to you to close us out.
Oh, thanks very much, Adam. And it just falls to me to say a whole heap of thank yous, and I am going to take a minute just to do this. So Deloitte, just to note, Deloitte have done this really extensive and groundbreaking work for free. It's pro bono, and there's been a whole team of people involved. So I just want to particularly thank Luke, Bonnie, Jennifer, Rosie, Marvin, Rachel, Chi, Robbie, and of course the Standout Allies and LGBTIQ network at Deloitte, because their work is absolutely amazing, and we're really, really excited about the potential for this to cut through, hopefully, a number of conversations and really strengthen the government's position. I also want to particularly thank the informants and focus group participants, and also people who participated in some of the steering groups and early meetings to try and shape up this research and make some of those really, really difficult decisions about what we could and couldn't find data on in order to be able to come up with some pretty robust numbers that would stand up to the scrutiny of Treasury. So particularly the Productivity Commission, the Victorian Department of Health, Northwest Metropolitan Primary Health Network, the Australian Centre for Sex, Health and Society at La Trobe Uni, Mind Australia and the University of Melbourne. And of course, LGBTIQ plus Health Australia, the Victorian Government LGBTIQ Task Force, the Department of Family Fairness and Housing, Telethon Kids Institute, Switchboard, Transgender Victoria, and especially a thank you to our very own Victorian Commissioner for LGBTIQ Communities, Todd Fernando, for his support of this project. And finally, I'd like to make special mention of the fabulous and very clever Associate Professor Adam Bourne, and we can all thank him virtually, who has not only chaired this panel today, but has been involved in the project from the very beginning and has given us hundreds and hundreds of hours of his time and expertise. And of course, finally, I'd just like to thank Simon and the incredibly professional team at Thorne Harbour Health for making this project happen and for wrangling all of us on the panel today. Thanks, everyone. Go safely.